Al-Wagan Hospital is 45 minutes drive from our hospital. And patient had a pelvic fracture with a systolic of 90. And patient was talking to the group and they called me. Can you accept this patient? I said, by all means, send him immediately. Yes, all the way. And then the patient was prepared to be transferred.
Hello, everybody. Welcome to a new episode of our podcast, our medical podcast, emergency medical podcast. Today, we have a very interesting colleague, Dr. Omar Bekdache, we will take you through a journey of trauma, treating trauma, managing trauma, and how that has developed. And we will talk about some of the newer concepts that have come in and that are being introduced in the region. So welcome, Dr. Omar.
Thank you, Dr. Naim, for having me. We have a long journey in educating trauma in this country, and we're collaborating a lot. Thank you for having me in this episode.
You're welcome. I know him quite a few years. We train trauma together, the Advanced Trauma Life Support course, which is an American College of Surgeons course. And it's an honor for me to have him here. He's training on trauma. He's training on resuscitative aortic balloon occlusion, which is a new thing in trauma. And it's really an honor for me to welcome you here and just have a discussion and talk about your experience and with this, with trauma in general and this technology. So I'll start by just asking you, what got you into trauma surgery in particular?
Yeah, thank you for having me, Dr. Naim.
You're welcome.
We've been through a lot teaching trauma in this area of the world. So I used to really shy away from trauma before. And everyone, when there's like something dealing with life-saving procedures, try to see, am I fitting into this particular place? When I was doing my medical school, my residency, I think that, it's not really my field. Until I heard something that is correctly true. Go face your fears. You hate something, you fear something, go face it. And this is what I teach as well my children. If you have something that you don't really like, you will try to shy away from it. You will find excuses not to do it until you step into it. And that's what I did actually. I went into digging into trauma. And then we were really assigned to have this educational program by 2006. I was picked among other surgeons and emergency doctors, among intensive care, and we were lucky to have a medical director that believes in surgeons. And he said, Omar, I want you to go. We are introducing this course called Advanced Trauma Life Support. Go ahead and learn it and acquire the knowledge, and I want you to bring it and then transfer it to here. And we were in Tawam hospital at that time. I was not really covering STMC at that time, so STMC is like a year ago. Yeah. And then we went to Fujairah, and the course was 1 year before started in the country. We went, the chief of the intensive care, the chief of anesthesia, chief of ED, and myself from the surgeon, among all group. And the director of the hospital was with us. And we went there, we did the course that we liked a lot. And we want to bring it back to the hospital to transmit and disseminate the knowledge. And here is the start of the scientific trauma. Until I said, now I know the science very well. What about the application? So applying trauma in emergency setting, life-saving procedures, patient that is bleeding to death is not an easy thing. So during my career, people were saying, okay, how we will do to bring trauma as well practice, the real trauma practice. This when I decided to stop my career and to go and seek trauma education and practice in Canada. And among all other objectives and goals, among them is just to go to this nice place in Canada. I went to a real renowned place in McGill University. And then I stopped for a while and went into a fellowship program. It was not the easiest way to be integrated into the program, the Canadian. And then I stayed to do a master's degree. And I was telling the story. I was like applying to this fellowship, and I was zapping on the TV, and I saw a report from BBC mentioning a new technique called Riboa, inflating a balloon inside the aorta for a patient that is bleeding to death at the roadside. So they went there and they inflated the balloon on a patient with really a bad pelvic fracture. They managed to survive the patient temporarily and contact the hospital. Patient was transferred and was saved, and it went viral. So I was like negotiating with my supervisor, what kind of topic shall we pick for my master degree thesis? And they said, okay, we're introducing this Riboa to McGill, so why don't take this and it will be your thesis. So I was into a master degree science again and taking fellowship hands-on in a well-renowned place in the world in Canada. And what happened at that time is that when I was a fellow, there was some conflict with whoever was doing the residency, and they stopped having junior and senior residents. So I was covering junior, senior, and a fellowship. So I stayed in the hospital literally. And they have low threshold to operate. Open thoracotomies, clamshells. I sutured heart with bullet injuries. They have lots of suicidal attempt, mitral jumper. So I was exposed really largely to trauma. And then returned back to the country to serve the country back with whatever they send me to do. So I'm now having ATLS and now having something in addition. Is this the balloon?
Yeah, I mean, it's interesting you mentioned that, the whole balloon thing. I'll just come to that in a second, because obviously I've been involved with ATLS as an instructor since about 2003 in the UK. And then during my training, I also did pre-hospital with HAMS, with the air ambulance service. And we were dealing with a lot of trauma. We were going to trauma essentially. So doing but really at that time, ATLS was teaching 2 liters of fluid. You know what I mean? That's all gone out now. And we've seen the whole thing
changing over time.
Change over time,
It should.
as it should.
If it stays the same, you will worry.
Yes. Right. Well, exactly. And I think, and I got interested in endovascular resuscitation or Riboa.
Well.
And this is a completely good field, a new field, and it makes sense. You know, intuitively. I mean, I think the data is not always there. It's hard to get data in this sort of practice because it's so critical. And to get consent and stuff for randomized trials is difficult. But it makes sense. If you can develop the technology in order to gain control of the bleeding, stop the bleeding internally, which is difficult to do from the outside, then there's hope for surgeons like you to then go in and do something definitive and save the patient's life,
which made the change nowadays in the ATLS teaching. So they used to use the famous mnemonic A, B, C, D.
Yes.
And now they change it for the first time.
Correct.
Stop the bleed first. X, A, B, C, D. Exsanguinating hemorrhage will kill you before the airway. We used to say airway will kill. Now exsanguinating hemorrhage is the killer. So if you have somebody that is bleeding, you interfere with the bleeding side, as we mentioned in the Congress all through the day. Until the age 45, trauma is the leading cause of death. What is the leading cause of death in trauma is hemorrhagic bleed.
Absolutely.
If you work on this, what they call the preventable, you cannot prevent death from herniating brain injury. So if I have a patient with a brain, I sometimes have brain coming out from nose or from, this is, even if you stop the bleed, you will not really end up with a survival.
Correct.
The only thing that will make an impact on difference is when you stop the bleed. The bleed is in the outside that you can see is easy to stop by pressure, by tourniquet, by wrapping, by whatever. What we teach the stop the bleed to the lay people.
Yeah.
And so in the hospital, the challenge is to stop the internal bleed. And here, as you're mentioning, logical. Instead of going major and stopping the aorta with a cross clamp, that will be a major, a little bit procedure. You can do this logically by inside rather than the outside. Hence the balloon inflation. But it's a temporary step. You have to have, as you said, surgeon back up. to stop the next step. It's giving you time, very precious golden hour that you have to act immediately after.
Beyond trauma, there's even uses.
Right.
So in surgical emergencies, bleeding, medical emergencies, like gastrointestinal bleeding, and now I think in cardiac arrest, there's trials going on looking at ways of maybe augmenting, coronary blood flow using a balloon.
Makes sense.
So it makes sense. I mean, obviously, I think the technology still is evolving, and it will improve. Like technology does. So I am very hopeful and of that this will be a future trend. I'm really glad that you're bringing it into the UAE because I think it's about time. I think certainly we should be center should be leading this sort of charge. I mean, we know that in this part of the world, trauma is in fact even a greater cause of illness and death than in other parts of the world, like Europe. So I'm glad you are doing that, and I'm so just I just wanted to ask you a little bit more about your. So did you use Rebo, or did you see Rebo at all in Canada? Or it's a new, you started in the UAE with it.
So when we started it in Canada, it was this new generation Rebo. So the previous generation failed a little bit to show a good outcome. It faded away from the literature until they invented a smaller caliber catheter that we tried to introduce in Canada, and they were selective at the start. And during my fellowship, before my graduation, we did 6 cases, which is a good number. Now they are at 45 cases, but the US are far away. So I'm still on the list of the Reboa group in the US. They are now at 1,500 cases, which is still showing improvement in survival compared to ED thoracotomy type. Now, this is what's happening in the developed world. We are in the Middle East. One of the leading countries, if not the major, is UAE, by all means. So I've been into all the countries in the area, you name it. UAE is a great system. So support, leadership, resources, places. So this is the time, as you're saying. It is about time. So now we have the balloon. We need to have the education, and we need to have the practice, and we need to be selective at the start. So what we are trying to do is just to disseminate the knowledge as through this Congress that we did today. We did a workshop that I think, inshallah, it will be a successful one. 2 hours hands-on, presenting how we can really do that. And as you are saying, it has other application than trauma. Makes sense. So I'm saying, I used to say that this is my baby. I'm defending that. Trauma in UAE is really high with all the development of the road traffic, network. It's really amazing. And you wonder how we can have all these trauma. So I used to chair the trauma committee for 15 years and report to the administration. 2,000 admission a year of trauma, too much. So non-traumatic use, by all means, I'm saying this is my baby, and we need maybe in every trauma and every arrest that is really advanced, complex, losing vitals, we need to have this as a plan B standby. It will measure your arterial pressure. You will apply all the other measures. Patient is responding, fine, you have an arterial line, patient will go to your ICU with an arterial line monitoring. If the patient will lose, you upgrade the arterial line immediately to a balloon.
Absolutely.
That will help you, as you mentioned, have a perfusion to your brain and to the heart, the noble organs. Of course, you will deploy the other organs, your lower extremities. Most of the patient that will survive will have ischemia, will have renal shutdown, but you save lives. And this is the main interest.
Yes.
So you occlude the balloon in, let's say, non-traumatic cardiac arrest outside the hospital, at home. Patient is coming in arrest. First thing, you deploy the balloon. You start the CPR. When you open the balloon, and the patient will have return of spontaneous circulation because of this afterload that is caused by the inflation of the balloon, will allow you to have the blood perfusion to the heart, myocardium, and to the brain. And hence people will have better return of spontaneous circulation, what we call the ROSC, compared to the non-balloon group
Methods, correct.
by 63%. So I will defend this balloon to traumatic cardiac arrest, non-traumatic cardiac arrest, and we can use it in other situations. GI bleed massive in ICU. If you anticipate a big surgery that will consume a lot of blood and blood loss will be enormous,
Correct.
you put the balloon, you start your procedure, you bleed, you inflate the balloon, you continue your procedure, take out whatever, and then deflate the balloon. It will give you this bloodless field for half an hour.
And
Precious, beautiful.
Yeah, and in fact, you just reminded me. There's got quite a lot. There's uses in it potentially in obstetric hemorrhage.
They use it
where
already.
people can,
Yeah.
you know.
My wife is a
woman may
gynecologist, so I'm biased.
Yeah, sure.
They are great people. So when you have a problem with post-delivery bleed, sometimes you need real measures. Sometimes you need to call the IR to go embolize your internal iliac that is given your uterine branch.
Yes.
Sometimes you end up doing hysterectomies post-cesarean,
Sure.
and sometimes you lose lives.
Yeah.
If you have a placenta that is embedded in the
embedded into
myometrium, it's called
accreta.
placenta accreta increta. So I hear these terms from my wife. And then you will try to separate this after delivering the baby. Baby is alive. And then the mother now is at risk of losing her life because of that. So you need maybe to stop the blood to the uterus and the pelvis until you
order
figure
to
out
be
what
able
to do.
yeah.
And if you don't do it quickly, you lose the life.
Yeah.
So yes, in OB, there is a
Definitely.
place.
I mean, it's and I think you mentioned something which
Yeah.
I really like. Which in fact, few days ago, I was talking to a colleague from the UK. He's a military consultant, pre-hospital, and they teach a course called SPEAR, which is endovascular resuscitation course.
Right.
And they did exactly what you do, which is essentially what they're saying is put in a femoral line to begin with.
What do you have to lose?
Correct.
You have it, an
any
arterial monitoring
unstable
device.
patient. And it because and they interestingly they said their data shows that even a radial artery catheter underestimates what the central pressure is.
Right.
So you need to get it into a big artery like a femoral artery, and that then gives you the opportunity, as you said, to then deploy a balloon if you need it.
You upgrade it to the balloon
upgrade it,
immediately
absolutely.
by a dilator and a sheet.
And-
it will take 10
correct,
seconds.
correct. And
And
you
I
can train
presented
a
the
lot of
video. Did
people
you see
putting
this video
femoral.
I presented?
Yeah.
On real life balloon deployment, less than a minute.
Yes.
At McGill, I videotape as well. A great guy, anesthesia. He is superb. When you have the skill, you will have this precious time saved. And I have him on video doing subclavian and doing this. I have him 18 seconds. He is in the artery with the sheet inside. Can you believe it? 18 seconds.
But I
In
think,
the best of hand,
look,
if I'm really quick in surgery, I have my videotape as well
Yeah.
doing idiothoracotomy. I have the heart in the hand in less than 5 minutes.
Yeah.
But you know how moribund is this.
Yes. It's a
You
huge
end
procedure.
up in 30% of the cases having blood on you.
Yeah.
This can transmit disease. You can injure other colleagues. While this going percutaneous ultrasound guidance, and it will give you nearly the same consequence.
Yeah, absolutely. I think, and the good thing is, I mean, from an EM point of view, I mean, you're here at EM conference, but putting a femoral artery, the skill of getting that in,
Should be easy for you
it should be
guys.
easy, and we can get a lot of people trained up on that first step.
Should be. You know,
And then once you had the first step, and as you said yourself, it's a practice thing. So the more you do, the better you get.
skill.
It's a skill, and
Practice makes perfect.
Practice makes perfect.
We had a great chief of trauma in Canada. What he did when he was believing in this balloon, he said, okay, every fellow should rotate 2 weeks in the IR. So you know how many they do the cardiac or the IR radiologist,
Yes.
how many they do a day, like a list of 15 or 20.
Yeah.
If you are in 2 weeks doing these
Yes.
ultrasound guidance, they are like tuck,
You're
and you're
expert.
inside the artery.
Yeah,
If you do this in trauma as ED,
Yes.
you can prepare the setup. If you have in the ideal situation trauma surgeon in-house,
Yes.
you can save lives.
Yeah.
Big number can be saved.
Yeah.
What we are having now, sometimes I really feel sad when I hear in the morning report, patient came with vitals, lost vitals, no one took action, patient arrested, rahmatullah alayh. This shouldn't happen, especially when we're penetrating. We don't have penetrating, alhamdulillah, aman, security, safety in the UAE. But when you will have it, and when you have the penetrating injury, patient will bleed to death in front of your eye. You don't take action, it will sit on your consciousness.
Exactly.
So you have to have the skill.
I'm really pleased that you're taking on the cause of Riboa. I think I spoke about Riboa in 2000 and just before Riboa, 2017 or something in Egypt in a trauma conference.
I did a workshop in Egypt as well.
Right. Yeah. So they asked me, actually, so did Turkey, Saudi, great Saudi.
Guy,
so he asked me, he was at the conference. So he was one of the moderators. So he said, do you know the cost of it? Do you think it's really worth? And I was like, listen, Anita, how do you answer that? And I was like, but what's the right my exact response? How do you value a life? And that's how you
a relative, a family of yours. Sometimes I present M&M cases, and I'm a little bit aggressive in resuscitation, and I get criticized in the M&M repeatedly. And then my answer will be, if this is your relative, you want me to do this 1% survival in blunt trauma? Is this 1% is your family member? You want to give him a chance to survive a blunt, penetrating 25%. 1 out of 4 of penetrating exsanguination with arrest will make it. Neurologically intact. Can you believe this number?
Absolutely.
If you don't intervene and the patient will die, imagine. This is priceless if you want to put a price on a life.
Exactly.
Haram. This.
I do have a final question for you, which is interesting. So obviously we talked about so far deploying Riboa or the balloon mainly in the ER, but there is a concept of trying to do this pre-hospitally.
Right.
So those who are bleeding very large amounts, or so obviously I think that's something that will come later, because we can't go with that straight away, and we don't often have hospital-based or doctor-based teams in the pre-hospital. So maybe it is difficult, but how do you feel about that? It just as a feeling, rather than as a, do you think that's something that maybe once it's established, we look into deploying?
Quick answer, not the time here.
Okay.
Why? There was a study, and it's a very famous study, about what to do at the scene. Stay and play versus scoop and run. Scoop and run made a big difference compared to stay. Stay and play is do things like at the scene. Among them intubating, among them transfusing, among them Riboa at the scene. In the UK, the only example in Japan and UK, what they did differently, they dispatched the medical team with the paramedics. It's not only paramedics. The medical team is there. And the most important thing is not to deploy the balloon, is what's next. So you are gaining 30 to 60 minutes. If you don't prepare the next step, it's a failure 100%. So I think it has a place when we are prepared really well afterward, after the whole system has grown,
needs to be
matured, and then we know the next step. And maybe, yes, in this case, deploying the medics and paramedics to start while you are at your trauma center preparing for the next step. You are stopping an abdominal bleed. Patient is gonna die when you will deflate the balloon. You're ready to stop the bleed inside. It has a place.
Ready. Correct.
So I think down the road we can match this if the system will change. By the way, this is not applicable even in North America. Canada and US don't deploy at the scene. It's gonna fail because of the next step.
Correct.
Not ready. When you dispatch with the helicopter medical team to do that, it's a different story. Japan is really having an advancement in that, big time. But I'm a believer that this is a game changer. It has to have a place in the trauma armamentarium, we say. It should be learned by 1 or 2 team members in the emergency in case of need. And the need is happening in our hospital, let's say at least once a month, at least. I had, maybe we can close with that, a nice story. about a call from Al Wagan Hospital. Al Wagan Hospital is 45 minutes drive from our hospital. And patient had a pelvic fracture with a systolic of 90. And patient was talking to the group, and they called me. Can you accept this patient? I said, by all means, send him immediately. Yes, all the way. And then the patient was prepared to be transferred. And then his blood pressure dropped. They prepared him in the ambulance and he arrested. What they did, return back to emergency, try to CPR, declared dead. I was thinking, if this patient had the balloon at this institution and they send him 45 minutes drive, the exact time of the balloon, I'll be ready with my team in the trauma center to have a definitive hemorrhage control, be it in the abdomen or the pelvis. The patient will be with us.
Yeah.
It's a game changer. Hopefully,
it's a good,
we'll have the time to have.
Yeah. I think it's a good story or emotional story to end with. Because
Right.
it really highlights, what can be achieved and what can, because we will always have remote hospitals. We will all have people presenting to places which aren't major trauma centers.
Right.
So if we're going to save their lives, then we do need some a way of thinking that's not different to what we're doing right now. So thank you very much for that, Dr. Omar.
Most welcome. Thank you for having me.
Not at all. Thank you very much. What we've done today is talk about trauma management, in particular, moving on to the current concepts of endovascular resuscitation using a balloon. And it is something that Dr. Omar Bekdache as he told me, he's bringing to he's got experience and he's got training in, and he's bringing to the UAE. And we're really pleased to see where this will go, the next steps. With that, I will conclude, and until the next episode. Thank you.